Give me 1 minute. Hey. Hey, we have blondie. Sit, sit up. Come on.
I think we go live in 1 minute. Request everyone to mute their mics.
Srijan, it's 85% now.
Okay, sir. By the time your turn comes, if it's come, I'll download it here because I'll also need to download it.
Yeah.
If it doesn't happen, you run it from your side.
Yeah, will do.
Right. Good evening, everyone. Welcome to today's webinar brought to you by the IASO Academics. Today is the third chapter in our series of webinars called The Mastery of Surgery. To deliver the welcome address from IASO, I would like to invite our President, Dr. Sharat Desai, to kindly open the session.
Thank you, Srijan. And today we are going to come across one of the most common cancer which is treated all over India. And for today's lecture, we have the breast imaging is going to be spoken by Dr. Jwala Srikala. Welcome, Jwala. And the other tutorials, the sentinel node biopsy is being done by Dr. Ashutosh. And then Dr. Shakil Shamsuddin is going to talk about the oncoplasty techniques of the breast. And finally, the most advanced method in breast cancer today coming up, robotic mastectomy. For that, we have Dr. Sandeep Naik, the famous oncosurgeon from Bangalore. So thank you, Srijan and the Indo-American team, and let us proceed further.
Thank you, sir. The first talk for today would be on multimodal approach to breast imaging. This is like a primer to all the surgical oncologists who are live in the audience or who are viewing this later. And Dr. Jwala Srikala, who is the Chief of Medical Imaging and a specialist breast radiologist from Sindhu Hospitals, Hyderabad. She'll be presenting this topic. If there are any questions for Dr. Jwala, please put it on the chat box and we'll get to her immediately after her talk. Over to you, madam. You can kindly share your screen and begin your talk.
A very good evening to all of you. And at the very outset, I thank the Indian Association of Surgical Oncology, Dr. Subramanieshwar Rao sir, for having given me this opportunity. I'll try, and it's a very vast topic, but I'll try and finish it in the time that is given to me. So, as we all know, breast cancer is now the #1 killer cancer in India now, especially in India. And then, if you go through all the imaging modalities, there's a whole list of modalities that can be used to image the breast. But the most important being mammography, ultrasound, and some modalities of functional imaging, such as breast MRI, contrast enhanced digital mammography, and of course, the new kid on the block, the PET MRI. So, looking at mammography as a modality, that remains the mainstay for not only breast cancer screening, but also for symptomatic women who are above the age of 40. Digital mammography, of course, is much better than film screen mammograms, and of course, now we know that after the turn of the century, we are seeing a lot of digital systems coming in, and it does definitely scores over a film screen mammography, especially in women less than 50 years, perimenopausal women, women with dense breasts. In all these cases, the digital mammogram is much better than the film screen mammogram. And the sensitivity, of course, we know of mammography is almost up to 90% in women above the age of 40, but it does suffer in women who are between the age of 40 and 90, and we'll see why in a minute. So when we look at a mammogram, the first thing that hits us is how is the breast composed? So depending on the composition of the breast, we classify it into composition A, which is predominantly fat, through composition B, where there is scattered parenchyma, composition C and D, where the breast is extremely dense. So now you know why the mammographic sensitivity averages to below 80%. That's because of the inherent composition and density of the breast. So imagine a cancer in a woman with a composition B, white in white. There's every chance that I miss a cancer in this lady. So I need to supplement my mammogram with another modality. So when I start looking at a mammogram, I have to categorize the breast into one of these. So that tells me my confidence levels of picking up a cancer in this lady on the mammogram alone. Right. So once I look at the composition, now I'm going to look for abnormalities in which the cancer can be seen, which are mass, distortions, asymmetries, calcifications, or any associated indirect features such as nipple retraction, skin thickening, skin retraction, axillary lymphadenopathy, and whether the woman has an implant or she's been operated, are there any clips there? So all of these is what I'm looking for. And then once I see it, I follow what is called the PIRADS. I'm sure as surgical oncologists, you have read this time and again in our reports. And what basically we do is we use a set of words to describe an abnormality in the breast, and then we come to a conclusion and give it a number. When I say category 0, I mean that mammogram alone is insufficient. I need a supplemental imaging to be able to confidently say whether there's an issue or not. Category 1 is normal. Category 2 is definitely benign. Category 3 is probably benign. The chance of this lesion being a cancer is less than 2%, but nevertheless, I want to bring her back for 6, 12, and 24-month follow-ups. If there is no change in the size, I'm going to downgrade this to a PIRADS 2. Now, when I say category 4, a PIRADS category 4 is a suspicious lesion where the level of suspicion ranges from 2 to 95%. Now, because the range is so wide, we subclassify it into 4A, 4B, and 4C, where a 4A lesion, the chance of this being a cancer is about 2 to 10%. The chance of a 4B being a cancer is about 10 to 50%. The chance of a lesion classified as 4C is 50 to 95%. So what is it really, what is the implication does this have? It means that when I call a lesion 4B and I do a biopsy, I'm expecting a malignant pathology. But when I do a biopsy in a woman with a 4A and my pathologist gives a benign pathology, it is concordant. And if I call a lesion 4C and my pathologist says this is benign, I would consider it discordant, and I would like to either repeat the biopsy or take the help of a higher modality to be sure that I'm not missing a cancer. So that's what is the implication of these 4A, 4B, and 4C. Now, when I say a lesion is category 5, I say that there is more than 95% chance that this is a cancer, and a benign pathology I'm not going to accept. And this the possibility that this is a cancer is over 95%. A category C is given to a woman who already has a diagnosis of breast cancer. You're imaging her to look for the contralateral breast, or to look at maybe she's post-therapy, post-neoadjuvant chemotherapy. So now let's look at some of the common patterns that we look for in mammography. This is a 44-year-old with complaints of a lump in the left breast. You see, it's a relatively well-circumscribed mass, but quite dense when compared to the adjacent parenchyma. It seems to look quite benign. It's oval, horizontally oriented, but then you see the heterogeneity on ultrasound. So whenever I pick up an abnormality on mammography, I'm going to do a complementary ultrasound to see whether it is solid or cystic. And then it does look a little heterogeneous to me. And then I do a biopsy, and this is a mucinous carcinoma. This is just an example of a well-circumscribed cancer. This is a 50-year-old operated for the right breast. Hence, we are looking only at the left breast. And if you carefully see, there's a tiny little speculated tumor there in the central and the medial quadrant. That's a recurrence in the contralateral breast. And then we did the biopsy, and it was an invasive duct carcinoma. So our job just doesn't end at giving a diagnosis. Obviously, this is a non-palpable breast cancer, and it's less than a centimeter in size, and my surgeon wants to do a breast conserving surgery. So I kind of localize it with a wire, with ultrasound guidance, and we help the surgeon in wire localization and a subsequent wire guided excision, where as the woman is on the table, the specimen comes to me just to be able to be sure that the margins of the lesion, the excised specimen, are clear of the diagnosed tumor. So that was a 5 mm invasive duct carcinoma. This is a 53-year-old for screening mammography. She came in because her sister in the US was diagnosed with breast cancer. And if you pay some attention, you see that there are areas of distortion in the right breast. So this is an example of a distortion in the breast. There's a distortion in the outer half. If you pay attention, you also see that there's an area of distortion, a similar area in the left breast also. So that's what we say. No satisfaction of search. Please look for more when you pick up one. So there are 2 lesions in both the breasts, one in the right, one in the left. And if you closely see, there seems to be some amount of associated microcalcification. So once I've looked at distortion, it's only detection. I'm not going to diagnose it just based on the simple CC and MLO views. I'm going to get the woman back, do paddle views, a spot compression views to be sure that this is actually a true abnormality and not a summation because of overlap. So now this is a right spot compression, this is a left spot compression, and you can see that clearly there's an area of distortion. And in fact, in the left breast, there is associated microcalcification. I do an ultrasound, and I can see both on the ultrasound. We did the core needle biopsy, and both turned out to be invasive carcinomas. And because they were very, very small, we did wire-guided wide excision in both the breasts. And 15 years since, and she's doing fantastically well. Now, this is a 35-year-old with a vague mass in the left breast. She went to multiple centers elsewhere, and they said she was fine, despite she's saying that she's actually having a palpable abnormality in the left breast. I know she's only 35, but then one must remember that the cutoff of 40 is for screening mammograms. When it is a woman younger than 40 and clinically it is suspicious, you can go ahead and do a mammogram. If you're thinking of a cancer in somebody less than 40. So the age of 40 is only for screening mammography, not for diagnostic mammograms. And now you agree with me that because she's very young, the breasts are extremely dense. This is what I say, a category D breast, where it's very, very easy for me to miss a cancer. But then if you focus carefully, her medial half of the breast just shows fatty parenchyma, which is black, and it is replaced by this white tissue in the left breast where she was complaining of a palpable thickening. And now when I do the MLO, the retroglandular plane seems to be quite okay on the right, but you see this big mass sitting there in the retroglandular plane because it is very deep. deep and the breast is quite large, the lesion was also missed on ultrasound because they didn't look at the deeper structures in the breast, and that was a 5 centimeter breast cancer. Unfortunately, recurred after 8 years, and she's currently undergoing therapy for her recurrence on the right side. So this is the algorithm that we follow whenever we pick up a distortion or a tiny little speculated mass or a sub-centimeter abnormality. We try and do a paddle view and then look for the abnormality on ultrasound. If it's solid, we go ahead and do a core needle biopsy. Now let's come to the other common abnormality that we encounter while looking at early breast cancers, which is microcalcifications, which is kind of a Waterloo for even the most experienced radiologist. So it's a 47-year-old. She came for screening, and if you look carefully, there's a cluster of microcalcifications there, and that's where it is on MLO view. So we always do a MAG view to be sure that we are looking the kind of calcium, to evaluate the kind of calcium. We're going to look at a magnification view and then be sure. So that's the magnification view there. So as clinicians, please insist that the radiologist does these MAG views before they sign off saying that the cancers are benign, because the routine mammo is just detection. It's not diagnosis. It's only after I do these special views that I can be sure that I'm looking at not so good microcalcifications. Now, if you notice, we just saw a few specks on the routine mammo, but when I do these MAG views, I see many, many more. As well as I'm able to see the morphology of the calcium much better than in my regular views. So now I'm sure that this kind of calcium is probably within the duct, and I know for sure I'm looking at an in situ carcinoma, if not with a early focus of invasion. So we did a stereotactic core biopsy because she did not have a correlated ultrasound abnormality. We did a wire-guided excision, and that's the specimen for you. And you can see that the entire calcium of interest is out in the specimen. We compare it with the primary mammogram to be able to tell the surgeon that the excision is complete. Now, that was an infiltrating carcinoma, so there were areas of microinvasion. So even though we picked it up so early, this is another example of a 50-year-old who came for a screening mammogram, and you see this subtle powdery kind of microcalcifications. That's the MAG view, and you agree with me that there's a lot more on the MAG views than we see in the regular views, and it was already invasive duct carcinoma. Now, sometimes all these examples are of a 2D mammogram, but sometimes what happens is because of the overlap of tissue, we might miss cancers, or we may overcall certain blobs of white tissue that we see as abnormalities. So in order to overcome that, the newer addition to our armamentarium is the tomosynthesis. So what does tomosynthesis basically do? Basically, what it does is it slices the breast like, this loaf of bread that you're seeing. It basically slices the breast into 1 millimeter thickness slices. So I'm able to separate the overlapping tissues and be able to make better diagnosis. So basically, it's like getting a CT scan of the breast, to put it very crudely. So that's how a tomosynthesis machine looks. And basically, that's what it does. It kind of rotates around the breast, and we get these slices of tissue. And believe me, the resolution is so fantastic that I can reconstruct the 2D effect from the n number of slices that are inside. So for those of you thinking that the tomo may cause patient dose to patient, in fact, now the technology is so amazing that once, within a month or two of starting to do tomosynthesis, we completely do away with 2D acquisition, and we only acquire 3D images and reconstruct our 2D from the 3D data set. So this is just an example to show you. You see that speculated mass there in the upper half of the right breast. You see the tomo slice shows the margin so much better than the 2D image. And this is just to show you the cine images that we run through while we are reporting. Now, interesting is that in the tumor, I don't see just one, but I see another focus of cancer superior to the primary mass. And this tumor was looking quite benign on the 2D mammogram. And it's only suspicious when I look at it on the tumor. You look at the anterior margin, even this lesion seems to have speculated margins, right? So this is another example of tomosynthesis where there is a tiny little lesion there in a dense breast. I can't really comment well on the margins of the lesion, but if you see the tomo data, you can see the margins so well. I know I'm looking at a speculated mass. So this is a 40-year-old software engineer. She came for her first screening, and behold, it's such a dense breast, and I wouldn't be able to say anything. But when I run through my tomosynthesis images, you'll be surprised to see that she has a speculated mass in the outer and upper quadrant of the right breast. So due to want of time, I'm not going to be running through these tomo slices. Just to tell you, that was the tumor. You can see the retraction of the parenchyma there, and that's how subtle cancers can be and so difficult to interpret in women who are young, relatively young in their 40s. Now, that was an IDC. And so how does DBT perform in cancer detection? It definitely helps in picking up more cancers. There's a 30 to 34% increase in detection of early breast cancer, especially in women in premenopausal age and in women with dense breasts, irrespective of their age. And also it helps in decreasing false positive findings. So breast ultrasound, of course, we all know that's the workhorse for any radiologist. Every time I look at an abnormality, I'm going to turn to the ultrasound to know whether it is a solid or a cystic lesion. And of course, it also helps in evaluating all the palpable abnormalities, and it's the first line of investigation in women who are under the age of 40. And it also helps in second look ultrasounds in women whom we have referred for MRI, because there is a clinical radiological discrepancy, and mammo and ultrasound have not given us an answer, and we have picked up an abnormality on MRI. And when we go back and do a second look, 80% of women are able to see that abnormality that we have seen on MRI on second look ultrasound, which helps in easily biopsying it. Now, when we add ultrasound to a mammogram in women with dense breast, it increases the sensitivity from 75% to 97% in picking up a breast cancer. Now, that's a small lesion there. We know that's a cyst, that's a fibroadenoma, that's a juvenile fibroadenoma there. We know because the woman is young, that it's usually seen in teenage girls, and that's a Phyllodes tumor. It has a very classical signature on ultrasound because Phyllodes mimics fibroadenomas, but on ultrasound, we have this cliffs of fluid and that fibrovascular core and the increased vascularity, which helps us in differentiation of fibroadenoma from a Phyllodes tumor. Duct ectasia, intraductal papillomas, Bond is a very interesting and a very fascinating abnormality. It is superficial devices. Ultrasound is actually the mainstay of modality to diagnose this. Fat necrosis can be quite dramatic on ultrasound. That's where mammo helps us in picking up, because in mammogram, these are seen as lucent areas because fat necrosis is fat is black on radiography, on mammography. So this is another example of a tiny little tumor there. And when I do an ultrasound, I pick up this tiny little, relatively well circumscribed lesion, but it has certain margins which are very worrying. And for women in implant rupture, the first line of investigation would be a breast ultrasound. And when we see these floating membranes, we know that she's having an implant. Now, coming to functional imaging, which is now giving us much more information than we had earlier. So the mainstay of functional imaging in breast, for years it's been breast MRI. Now we contrast enhanced mammography to the armamentarium of functional imaging. Of course, PET, it doesn't have any role. For those of you who are new into breast imaging, remember PET-CT is only for distant disease detection, not for primary breast lesions. So if you think clinically you've palpated a breast cancer, you've done a biopsy, You think PET is going to show you multiplicity of the lesion or contralateral disease? No, not every time. There are so many things that are missed in PET CT, especially in the breast, right? So breast MR and CEDM remain great modalities, and we take advantage of neoangiogenesis that happens in cancer pathology of cancer. These new vessels are abnormally leaky and permeable. So when we put contrast, there's going to be contrast in these beds, and there is going to be a rapid washout of the contrast because of the arteriovenous shunting, and that's what we take advantage of. Breast MR extremely sensitive for picking up breast lesions, so we sometimes turn to breast MR in women with dense breast and high risk of breast cancer. But for DCIS, because it depends on the grade of DCIS and the neoangiogenesis, so the sensitivity of breast MR does suffer sometimes. So, and then also the specificity of breast MR is not as great always, because even normal breast tissue in a reproductively active woman can enhance and cause some problem in interpretation. So we have to keep that in mind when we are interpreting breast MR, and it does have a long learning curve. So if your radiologists are new in breast MR interpretation, please forgive them. It is difficult. It does take some time for us to learn breast MR and interpret them, because in a woman who is in her 40s, everything starts enhancing. Even the normal tissue is hormonally charged, and it will take up a lot of contrast. And it is difficult sometimes to tell an early cancer from normal tissue. So we all know the indications now, especially we use breast MR in high-risk women, especially the BRCA family. And this is what I mean when I say there is a rapid washout. And we do plot some graphs after giving the contrast to know whether this solid area, which is enhancing, is likely to be malignant or benign. But having said that, we do look at the morphology before we look at these kinetic curves. So the morphology, the margins, the appearance of the lesion scores over the way the contrast is passing through the lesion, because some low-grade cancers can have progressive enhancement. The contrast can still be going through it. But if it shows speculated margin, I would put my money on a cancer and not a benign lesion, even though the kinetic curve mimics a benign lesion. So this is a 33-year-old with a BRCA, from a BRCA family. Her genetic tests were pending. We did an MR, and you see there's already a relatively large enhancing tumor in her right breast. And when you do a mammogram, even after seeing it on the MRI, it's very difficult to say where the tumor was. Probably this area, which could have been easily missed if I hadn't seen the MRI. This is another lady who's BRCA positive on high-risk surveillance. These images that you see are very fancy. This is CAD. These are computer-aided detection, sometimes attached to our MR, which tells us how well the tumor is enhancing and which part of the tumor is enhancing. Now, this is a lady who's come from a BRCA family. I've done the MR and I don't see anything. And I can very confidently say that she doesn't have a cancer. So breast MR has the highest negative predictive value among all the modalities for breast imaging as on today. So as I said, DCIS, the sensitivity of MR is not great, but once you see DCIS, MR will tell you the exact extent of disease, because it can pick up non-calcifying DCIS very, very well, because that's not seen on mammography. So you see this lady with such a small area of calcification, but when you do the MR, you see all these areas of non-mass enhancement, which changes your management from breast conserving surgery to a mastectomy, because she has so many more areas of in situ carcinoma. This is an extremely interesting case. This is a 23-year-old software engineer, just qualified. She came to me with a complaint of copious spontaneous bloody nipple discharge. Because she's 23, I just went ahead and did an ultrasound. All I saw was a dilated duct in the lymph. Not show any intraductal lesion that I could biopsy. So I said, am I missing a DCIS? So even though she was 23, I subjected her to mammography, because calcification can be seen even in a dense breast. So to look for calcium, I did a mammogram, but I didn't see any calcium. And she did have copious spontaneous discharge. As I was scanning her, she was pouring blood from the blood. So I didn't have an answer for my clinical problem. So I turned to MRI. And on MRI, if you see, she had these two areas of non-mass enhancement well away from the duct that I had picked up on ultrasound. It was actually in the lateral quadrant. So I went and took the lady back into my ultrasound machine. I said, if I can see something in those areas, I'll go ahead and biopsy. But if the biopsy comes negative, I would have to refer her to a higher center which has MR-guided biopsy. And luckily for me, I did the biopsy and the result was an invasive duct carcinoma. So this is how MRI can be a great problem-solving tool, but one should know what to expect and what are the answers that you're looking for in MR before you order an MRI. Remember, the specificity is not great, so you have to be very clear in what you're looking for when you're ordering a breast MRI. This is a 42-year-old with an enlarged cervical lymph node. Somebody did a lymph node somebody thought it was TB, she was on ATC. Nothing happened. The lymph node was growing, so they did an excision, and it was metastatic disease. And after running a number of markers, they said this could be of probable because she was DADA positive. They said it's of mammary origin. A mammogram was normal, ultrasound was normal, and all I was left with was an MRI. You can see that she had tiny little cancer there in the breast, and I did a second look ultrasound, and I could pick it up for my medical oncologist. And because we already knew it was origin, I just clipped it so that, now she's almost a metastatic disease, and maybe we could do an excision after completion of her neoadjuvant chemotherapy. So after putting the clip, I did a mammogram, and you can see that even after clipping it, I really don't know which is the cancer there. So that's how subtle sometimes cancers can be. And this was a 45-year-old who was operated for an indeterminate lesion, which turned out to be an ADH. She was lost to follow up because of the COVID. And she came to me after 4 years, and I said, we saw an ADH in one breast, so she is high risk to develop a disease on the contralateral breast or in the same breast. So I did an MRI, and we picked up this non-mass enhancement, and I couldn't see anything on ultrasound. I referred her for a MR-guided biopsy, and it was a DCIS in the breast, contralateral breast. She had an ADH on the left breast, and we picked up this new DCIS in the right breast. So the other new modality that has come up, which is a part of the functional imaging, is contrast-enhanced mammography. This is nothing but injecting iodinated contrast. The same contrast that we give for CT scans is used in contrast-enhanced mammography, because the principle is just using X-rays to evaluate the breast after giving the contrast. So basically, we inject an iodinated low osmolar contrast, about 1.5 ml per kg body weight, and then we wait for about 2 minutes and take the routine CC and MLO views. And there's a lot of work happening in contrast enhanced digital mammography as we speak, and we are looking forward to this modality being a poor man's MRI and giving us the answers that we were looking for in the routine breast MRs that we were doing earlier. These are just some examples for you. This is a lady with a dense breast. You can see she was only 8 or something. I found this large lesion there, and I wasn't sure if I was missing multiple lesions because ultrasound was showing me a lot of heterogeneity. I did a contrast MR, and lo and behold, I saw multiple, at least 6 lesions in my breast, and I could confidently tell my surgeon that she had no problem, no disease in the contralateral breast, which is also very, very important in counseling the patient. This is another lady. We know there's a large cancer there, but she wants a breast conserving surgery. So instead of MR, I did a contrast mammogram, and I could clearly tell the extent of disease. And you can see in the MLO that the enhancement is going towards the nipple and just about stopping short of just about 2 centimeters stopping short from the nipple areolar complex, so that the surgeon gets a clear idea and can plan the surgery or neoadjuvant chemotherapy for women with this kind of disease, and it helps in counseling them. And then, of course, additional tumor. This I know this is a cancer. I don't need a CEDM for this. But imagine the woman wants a breast cancer in a CT. And I really offer that. I do a contrast and I find that she has a small focus there, which is enhancing. We do a second look ultrasound, biopsy that, and we know even that is a cancer. So now we know it's a multicentric disease, and you could counsel the patient accordingly for surgery or no, for conservation or no conservation. So this is a 40-year-old with a rapidly increasing mass. I put her tomos just to show you that no matter what, if the breast is very, very dense, there's very little that we can tell you when it comes to the extent of disease or the multifocality and multicentricity. So I did the tomo, picked up another additional lesion, but when I did the contrast, I could see that this entire quadrant had so much of disease in this lady. And if you closely see, I also picked up this multicentric focus there, far away from the primary region of cancer. I looked at it on the ultrasound. I didn't pick it up, honestly, on the first look ultrasound. After seeing the CEDM, I did a second look ultrasound, biopsied this, and it turned out to be multicentric breast cancer. So this was a patient with a palpable lymph node in the left axilla, which was positive for metastatic cancer. So instead of a breast MR, I just did a contrast mammo, and you see it's clean. She has no focus in the breast, and all that she had was a metastatic lymph node in the left axilla. So to conclude, one has to have a step-by-step approach when you are evaluating breast lesions, especially breast cancers. Of course, we start with a mammogram, especially in a diagnostic setup. We start with a mammogram if the woman is about 40. We add an ultrasound to that. And if you're looking for more information than these two, we turn to functional imaging, which is CMR or the CEDM. So thank you very much for your attention. I'm sorry, I think I overshot. It was a lengthy talk, and thank you very much.
Thank you, Dr. Jwala Shikala. Really made your point clear that a good surgeon can be a great surgeon only if he has a equivalent companion in a very competent radiologist. I invite our surgical faculty, who are all themselves experts in the field of breast surgery. Dr. Ashutosh Mishra is here, Dr. Shafiq Shamsuddin is here, and Dr. Sandeep Naik is here. So any points that they would like to add or clarify, or talk about how this MDT approach to surgery actually helps them in the OR. Dr. Ashutosh.
Yeah, so actually I have a question. Most of the time in our clinical practice, we do see a lot of the post-lumpectomy patient usually visit our OPD. They have a lumpectomy outside visiting our OPD. Then how to address all these patients? What are the modality of choices?
So
what should be the sequence?
Like if they had a lumpectomy elsewhere and you're not sure, that I assume you're not sure of the margins, because we see this every other day. They do a lumpectomy somewhere because they think it's benign and the margins are positive. You want to look for residual disease to give her a definitive therapy. So I think breast, as on today, breast MR is great for looking at residual disease, because the residual disease is extremely subtle. So CEDM really is not yet there when it comes to post-operative bed residual disease. So breast MR is a great tool. And I think that will help you to know if there is residual disease or not.
So any other specification for breast MR, or it's simple breast contrast MR?
Any other indication would be a BRCA family. That would be the first and the foremost. BRCA women with dense breasts. You could. You're asking about breast MR or CEDM?
Yeah. So I am asking. We have advised for breast MRI in a post-lumpectomy patient. So are we advise any other specific breast MR protocol or something?
You must remember that, I'll tell you this because unfortunately, even in my fraternity, not many people, because of the sad state of diagnostic centers, many people do not know that there's nothing like plain breast MRI. There's nothing like a plain breast MRI, for the simple reason that I completely depend on my contrast, kinetics, and dynamics to tell whether a lesion is benign or malignant. So there's nothing like plain breast MR. So breast MR in the context of breast cancer is always contrast MR. It's only when you want to look at implants that there is to look for only implants, it's a plain MRI. But again, in a woman with implant, if you want to look for cancer or if there is a cancer in the native tissue, again, you need a contrast. So you just have to say breast MR with dynamic contrast enhancement. That should suffice. That should be good.
Dr. Shafiq?
Yeah, excellent talk, ma'am.
Thank you.
I had a few questions. I know there is we might be running short of time, so I'll quickly put across the questions. One is regarding contrast enhanced mammogram. I recently had a patient who was seen by one of the very famous radiologists from my state, Kerala. And she had presented with occult breast cancer and, lymph nodes biopsy proven without any primary. So for some odd reason, madam had decided to do a contrast enhanced mammogram rather than an MRI. So I was wondering, and you had in your last slide shown that, contrast enhanced mammogram one step higher than MRI. So is there any place where it scores over MRI?
The specificity.
Yeah. Okay.
Because what happens in breast MR, as I was telling you while I was doing breast MR part, that breast MR is extremely sensitive. So it picks up a lot of normal tissue, also starts enhancing. Whereas in contrast enhanced digital mammography, the routine, the adjacent normal parenchyma doesn't enhance as much. So my specificity is higher. So there are a lot of studies that are coming in to tell us that CEDM scores over CMRI in terms of specificity. So when I call a lesion a cancer in CEDM, I'm more likely to be right than wrong, when compared to CMRI. So the specificity is very good in CEDM. Now, but the disadvantage of CEDM is that I'm not sure how well it does in low-grade DCI. Because low-grade DCI doesn't have so much of vascularity and neoangiogenesis. So, but MR being more sensitive, I'm sure it's going to pick up better. So CEDM, we are still seeing how it's going to perform in low-grade DCIs, but high-grade DCIs, solid lesions, it kind of the adjacent tissue doesn't enhance as much as it enhances in CMRI and confuses me. So in terms of specificity, CEDM does slightly better than CMRI.
Sujan, can I ask one more question?
Sure, please.
Yeah. My second question is regarding radiologic interpretation of the breast anatomy. I'm biased by my area of special interest, which is lobar breast surgeries for breast cancer. Some of the cancers that you showed, around 20% of them that we see in our practice, they seem to spread and involve an entire lobe. Yeah. And I've been an ardent follower of Laszlo Tabar and Tibor Todd's work. Yeah. So I've been trying to find out a surgical solution for that by looking at lobar surgeries. Till now, I've been relying on, there's a septum in the breast, which people hardly talk about, called the Wuringer septum, which divides the breast into a cranial 2/3 and a caudal 1/3. So that actually acts as an embryologic compartment for the breast. So as of now, all I could find was when there's such extensive disease, I just proceed with a compartmental resection or a hemimastectomy. Okay, so madam, what I wanted to know from you was I came across some Japanese literature showing attempts at delineating the lobar anatomy using ultrasound. So can you shed some light on that? Is it actually possible to delineate the medial and lateral extents of the lobe on ultrasound? I think they were using special probes which were almost 10 centimeters long with a very high frequency.
Yeah, that's exactly what I'm saying. So we need extremely high frequency probes which have very, very high resolution, and also at the same time have penetration. Frequency, as you know, the frequency is the penetration of the sound waves.
Could you speak again, madam? You lost your voice here.
Hello.
Could you speak again? Yeah.
Yeah. So we need high resolution probes which have high frequency as well as good penetration to be able to identify those fine septae which separate the lobes. As of now, in clinical practice, I don't think we are yet there because the maximum width, because to look at the breast in its entirety, I need a probe which is at least 8 centimeters wide. It's only 10 that I'm looking at in total. So that is not available. The maximum width we have is about 5 centimeters. But let me see, there is something, we have now the 3D ultrasound, 3D automated ultrasound, where we get a coronal, sagittal, and axial 3-dimensional reconstructions live as I'm scanning the patient. Maybe these can help us in identifying these fine divisions in the loba, in differentiating these lobes of the breast. I think 3D ultrasound should be able to help us because it's a volume acquisition, not a piece acquisition. So I think the volume probe should be able to.
Right.
Thank you.
I think we have a couple of questions from the audience. If you could give a answer here, Dr. Ishfaq wants to know any technical difference between a diagnostic and a screening mammography from your side today.
Sorry, can you come again?
Any technical difference between a diagnostic or a screening mammogram?
No technical difference.
Perfect.
See, it's only what I was trying to say is once it's a diagnostic mammogram, I think the age is out of the window. As I showed you, I did a mammogram for a 23-year-old because I don't know why she was pouring so much blood, and I needed an answer for that. And for those, I don't know how many radiologists would be here, but even if the density is very high, microcalcification can end up in a dense breast. The density of breast doesn't limit diagnosing microcalc. It limits diagnosing distortions and masses. It masks the masses, but microcal I can pick up. So it doesn't matter. So what if she's young? The benefit of doing a mammogram far outweighs,
that point we understood, madam. Yeah, we understood that point. The second question was, is contrast enhanced digital mammography done with the normal mammogram machine or with the tomosynthesis machine? And would it be more specific with the tomosynthesis machine?
As on today, we do not do tomosynthesis after giving contrast. After contrast, we do only 2D acquisition. That's number one. Number two, tomosynthesis is one function. Contrast is another function. It's a completely different function of the same machine, right? You may have a 2D and still be able to do contrast. I have a tomo and also a contrast added on to the machine.
Got it. Thank you so much, ma'am. I think you answered all the questions very patiently, and I think it was a real value addition to have you with us. We move on to the second part of our session today, which will be the surgical tutorial videos, and we begin with the first one. We have with us Dr. Ashutosh Mishra, who's the Associate Professor in the Department of Surgical Oncology at AIIMS and National Cancer Institute, New Delhi. And his topic of presentation today would be the sentinel lymph node biopsy for axilla. Over to you, Dr. Ashutosh.
Very good evening. So we are going to discuss about the sentinel lymph node biopsy in breast cancer. So here we are going to discuss about the dual dye technique, indocyanine green and the blue dye. So sentinel lymph node biopsy, the concept was inducted by the Giuliano intraoperative lymphatic mapping and identified the sentinel lymph node using only blue dye. Thereafter, Craig investigated and they shown the use of radioisotopes for sentinel lymph node identification. After that, Albertini was the first to identify the sentinel lymph node using a combination of blue dye and radioisotope. Thereafter, Simmons first reported the methylene blue dye could serve as an alternative to isosulfan blue. And as of now, there is a gold standard is blue dye and radioisotope in combinations. But over the period of time, indocyanine green has evolved, and right now this green gold is in highlight, and it might be the next gold standard ICG with methylene blue dye in most of the settings. So what are the different techniques? So conventional are the blue dye, radiocolloid, blue dye plus radiocolloid, it's gold standard as of now. Then ICG, emerging technology. Now we can say it has already emerged and evolved, and it's being practiced in most of the centers across the world. Other techniques are supraparamagnetic iron oxide, contrast enhanced ultrasound with microbubbles, and Sentimag. So what's a fluorescence guided surgery? So basically it's a technique used to detect fluorescently labeled structure during surgery. And it provides a real-time visualization of the operative field, so that actually helps the surgeon to find out the exact anatomy and to find out the target organ of the interest for surgery. What's a fluorophobe? Fluorophobe is a fluorescent compound that can re-emit light upon light excitation. So when we throw light on a particular substance, then it absorbs and throw it back. So examples are indocyanine green, methylene blue, 5-aminol levulinic acid, then fluorescein sodium. So these are the different compounds that can be used as a fluorophobe. And ICG, actually, it has high contrast and sensitivity because the near infrared light used to measure fluorescence makes tissue appear more translucent, so they are more visible. Its depth of penetration is 2 to 4 mm and usually excited between 715 to 800 nanometer. And it usually comes in the powder form, and we need to reconstitute it with aqueous sterile water, the pH of 6.5. And it has quick clearance rate. It clears very quickly from the liver and usually have half-life of 3 to 4 minutes. So how this imaging system works? So NIR light source, it's a LED or laser light. There's a different components: NIR light, NIR fluorescent agent like fluorophobes, then imaging system, excite and detect fluorophore. Then NIR can be combined with white light and red, blue, green spectrum for real-time anatomical visualization. So there are a lot of things that we can see. So in this picture here, you can see there is the light source. This is the NIR camera. So light is thrown from the hair to the target organ, and dye is injected into targeted for the targeted organ. If in breast, then it can be injected directly, or if we are seeing the perfusion assessment of the flaps, then through the IV. So light is thrown from here, it excites and the picked by a near infrared camera. So this is how it works. This video is actually shot on Stryker SPY-5 system. So this is the console, it is the processor monitor, and this is the handheld device. So from here you can manipulate the system. You can change between the different modes of the camera. And this is the dye orograph that we are using currently in India most of the time. It usually come in 25 milligram. It's powder form. So we reconstitute its 10 ml of saline, 2.5% solution. So for this axillary sentinel lymph node biopsy, we should be aware about the different anatomical position of axillary lymph nodes. So this is the classical anatomical system. Level 1 is lateral to the pectoralis minor muscle, level 2 behind the pec minor, and level 3 is medial to pec minor muscle. So the level 1 is lateral to pec minor, and this is the area of interest. So most of the time sentinel lymph node is located in the this anterior group of lymph nodes. So it's Lee classification system, another system. So here intercostal brachial nerve divides the upper axilla and lower axilla. So in lower axilla usually find sentinel lymph node, and is the most latest classification of axillary lymph nodes. Here, this is the zone A, that is the medial to LTV, long thoracic vein, and below the intercostal brachial nerve. So this is the area of interest. Here you need to look for sentinel lymph node, and most of the time we will find sentinel lymph nodes here. And this is the photo of axillary dissection. Here we have preserved most of the axillary nerves. This is the second intercostal brachial nerve. Here you can see the long thoracic nerve, thoracodorsal artery vein and nerve, and this is the axillary vein. And this is the pec minor muscle. Here you can see this pec minor muscle. Just below that pec minor muscle, you can find out the sentinel lymph nodes. So this is the video of sentinel. So in this particular case, actually, we have done sentinel lymph node biopsy by dual dye technique. It's a post-NSCT setting. So a patient has received neoadjuvant chemotherapy, and after that we are assessing sentinel. We are doing sentinel lymph node biopsy. So 2.5 centimeter size tumor that's completely vanished. Now we are injecting the methylene blue dye. We are injecting subcutaneously. So you can go a bit deep. Usually avoid to inject methylene blue in the skin. Don't give intradermal injection, otherwise it may cause the skin necrosis. So go deeper. So you can give at two sites, at 3 o'clock position if you are doing on the left side, and 9 o'clock position 1 ml at each site. And then after giving the injection, do a good massage in roll out way. So from nipple towards the axilla, do it for at least 7 to 8 minutes or 10 minutes. That would be better. This is the ICG. That should we usually give this intradermally, 0.05 cc. So here you can see you should be very careful. There shouldn't be contamination of the field. And while you are injecting methylene ICG dye, then there should be the bleb, raising of a bleb here you can see, and take out very gently without any spillage. Again at 12 o'clock position by similar technique. Once you have given, immediately with the help of this spy system, you just put your camera 25 centimeter away from the target organ, put the monitor just in front of you as we do in the laparoscopy. So here this is the color segmentation mode. This is the fluorescent mode, spy mode. This gives the maximum sensitivity. And this green mode is when white light is combined with the fluorescent. This is the overlay mode. So here you can see the anatomical picture along with the fluorescence. So if you are doing real-time surgery, real-time navigational surgery, then overlay mode is quite helpful. And this red, blue, and yellow zone, actually red is the area where maximum concentration of ICG is there. And so immediately after giving the dye, we can see there is a trickling of ICG into the lymphatics and it's going towards the axilla. So that's a beautifully seen lymphatics that's going towards the axilla. And you can actually find out the point where exactly it's dipping into the axilla. And just wait for 5 to 7 minutes. Then you can again see you may go beyond that particular point, and that can give you a new point of dipping into the axilla. So just mark the point. So here you can see earlier we picked the 1 point, then there are 1 centimeter away. So it's just below the axillary hairline. So that's the point. And after that, you are not able to see the fluorescence. So this is the drawback of ICG of this particular system. You cannot see beyond the depth of 8 to 10 mm. So it's not very helpful in very obese patient or something when there is a lot of subcutaneous fat that it may misguide you. So in this particular patient, non-obese patient, that's a drawback of ICG. So you can find out the point where the axilla lymphatic is draining into the axilla, then place your incision. So usually 3 to 4 centimeter size incision placed in the lower axillary hairline. And as we do the sentinel lymph node biopsy, just deepen your incision, cut the subcutaneous tissue gently. So actually it's a sentinel lymph node biopsy is a minimal invasive procedure where you shouldn't damage much of the axillary tissue. So here you can see after breaching the subcutaneous fat and dividing the clavipectoral fascia, you can just see the fluorescent in the axilla. In the screen, in the monitor, you can see there is a fluorescence. You can see the fluorescence in the monitor. Then just gently delineate the tissue, and in the real time you can see over the monitor that fluorescent is there. So while digging into the axilla, be very cautious, because if you injure any of the lymphatic, then there is a lot of spillage of the ICG dye and your entire field will be doomed. So then it will be very difficult to identify these sentinel lymph node. So in this particular, it's post-NSCT setting and we have injected dual dye. So here you can see this blue lymphatic. This is the blue lymphatic that draining towards the lymph node. So you can just chase the lymphatic. So before chasing, just clip the lymphatics and divide it. So it will not contaminate your axilla either by blue dye and ICG. So we found a small lymph nodes. It's not blue and it's not very fluorescent as well, but it encountered in the path. So we just remove this node. It might be or might not be as it's a post-NSCT axilla. It might or may not be sentinel lymph node. So there was limited fluorescence. We kept this for frozen section. Again, we target the axilla and we see a lot of fluorescence is still there. And again, dissect very gently with the help of right angle. And again, here you can see there is a lymphatic and there is a blue dye. So this is the color segmentation mode. Here you can see there is a redness, a deep intensity of fluorescence, and that's a lymph node where both blue dye and fluorescence is there. So it might be. So again, we clip the lymphatic so that it will not contaminate the axilla, then divide the lymphatic and take out the lymph node gently. So here you can see blue lymph node and it's fluorescent as well. We have checked with the color segmentation mode as well. Yes, here in this spy mode or fluorescent mode, you can check it again and again. This is fluorescence. This is overlay, white light with the fluorescence. Then this is the color segmentation mode. So we have confirmed that this node is blue and fluorescent, and then we take it out and we clip the lymphatic. So it's very important to clip the lymphatic. So this is the disclaimer while you are using the ICG dye, always clip the lymphatics. Otherwise, there is the discharge of fluorescent ICG dye from the lymphatics. It will ruin your field, then you will not be able to find out any other further lymph nodes. So here you can see there is a intense fluorescence and there is a very limited fluorescence in the periphery. This is a color segmentation mode. So in this you can very well appreciate that in the fatty part there is a limited uptake. So you can just remove that particular part with the help of scissor and can send the actual fluorescent part for frozen section. Again, so after sending that particular node for frozen section, again go into the axilla, dig very gently into the axilla, check with the fluorescence. If there is no further fluorescence or blue dye or any palpable node, then that completes your procedure. So another advantage is the quantitative analysis that you can do by this Striker system. That so we have a study in 2021, a pilot study evaluating the sentinel lymph node biopsy using dual dye technique with ICG and methylene blue. And we found out by combination of dye, there is the false negative rate is less than 10%. It's 8% in our study. And ICG alone, it was 95% identification rate. And by combination, it was 97.5%. So there is a lot of other use of ICG in breast surgery, skin flare, myocutaneous sentinel lymph node biopsy, axillary reverse mapping, lymphedema assessment. So these are the other advantages. So sentinel lymph node biopsy you can do by methylene blue dye if you are working in a new setup, but there is the identification rate is around 80 to 90%. So you need to be a bit expert in injecting the methylene blue dye and do proper massage, but it's doable and you can start your practice with the methylene blue dye. If you have the facilities of radiocolloids, then you can use combination of dye, and if you have the facilities of ICG, then either you can go with the ICG or with the help of ICG plus methylene blue as a combination. And it's you can use in post-NCT setting also. So it's constantly evolving. It's a surgeon dependent procedure. You not to be dependent on the nuclear medicine person, but swift planning of procedure is very important. And single dye in upfront setting, more than 90% identification rate and less than 10% of false negative with single dye, particularly for ICG. Thank you so much.
Thank you, Dr. Ashutosh Mishra. What we'll do is we'll complete all 3 surgical videos and discuss in the end the Q&A with all the 3 faculty together. Now I invite Dr. Shafiq Samsuddin, who is a consultant in the Department of Surgical Oncology at the MBR Cancer Center and Research Institute, Koikor. And he'll be speaking, rather showing his video tutorial on the Oncoplasty techniques. You can share your screen, Dr. Shafiq.
Thank you, Srijan. Is my screen visible now?
Not yet.
Now?
Yeah.
Okay.
It's not full screen yet.
Okay.
Make it full screen.
Yeah.
Oh, yeah. Go ahead.
First of all, I would like to thank IASO leadership and the coordinators of this program for giving me this opportunity. I know it's a very vast topic, so I have chosen to give an overview. Perhaps we can clarify in the Q&A session as well. So I'll go straight to the presentation. Good evening, everyone. I would be presenting an overview of oncoplastic breast surgery techniques. Oncoplastic breast surgery is defined as partial mastectomy, ipsilateral reconstruction, and possible contralateral symmetry surgery when appropriate. The ideal result has 4 requirements: short-term rapid functional recovery, long-term minimization of local recurrence, robust aesthetics, and patient satisfaction. As Blake Cady famously commented, if biology is king, then patient selection is queen in surgical oncology. The greatest contribution of oncoplasty has been to facilitate more breast conservation, and the ideal patient has either one of adverse tumor breast ratio or a high risk of margin positivity or a poor outcome with total mastectomy and whole breast reconstruction, especially patients anticipating adjuvant radiotherapy. Besides, it is crucial to remember that risk factors like smoking, uncontrolled diabetes, obesity, and immunosuppression can increase risk of complications. Also pay crucial attention to local factors like skin and soft tissue quality, parenchymal volume, breast density, level of doses, as well as the availability of soft tissue in probable donor sites like the lateral thoracic area for planning chest wall perforator flaps. A useful guide for the novice surgeon starting on oncoplastic breast surgery is this landmark publication by Krishna Klo from 2010, which describes a quadrant by quadrant approach to various oncoplastic surgical techniques. Klo describes a bi-level classification wherein level 1 procedures are indicated for resection ratios up to 20% of total breast volume, and level 2 procedures involving extensive skin redraping and glandular reshaping are indicated when the resection ratio falls in between 20 to 50%. Besides, level 1 procedures are ideally suited for patients with dense breasts, whereas level 2 procedures can be attempted in both dense and fatty breasts. Another useful classification is into volume displacement versus replacement procedures. Volume displacement involves tissue from within the breast used for defect closure, is indicated for large volume ptotic breasts, and comprises simple or complex mammoplasty, whereas volume replacement brings in tissue from outside the breast, is indicated for small volume non-ptotic or grade 1 ptotic breasts, and comprises of autologous tissue flaps like chest wall perforator flaps, LD flaps, and even free flaps. Level 1 oncoplasty includes 6 steps, which begins with oncoplastic incision placement along the lines of relaxed skin tension or at the junction of 2 aesthetic subunits of the breast. The scar can often be decoupled from the parenchymal incision, which should ideally be oriented radially in the parenchyma towards the nipple. Shorter scars are not always beneficial in that they may limit parenchymal mobilization required. Vertical incisions in the lower pole of the breast heal very well, and it may be useful to place a tension line incision a little inferior than directly over the tumor so that the scar in the future is spared from the contractile effects of a healing and contracting cavity located directly below it. Step 2 after skin incision is skin undermining to take care of the radial margins, followed by step 3, which is NAC undermining to prevent a future NAC deviation. Step 4 is a full thickness glandular excision to take care of the anterior and posterior margins. Step 5 is a careful glandular reapproximation to prevent future seroma as well as deformities. And step 6 is NAC recentralization. This image shows the technique of NAC recentralization, which is directed not just diametrically opposite to the incision, but also slightly superior to account for the later effects of gravity as the breast descends over time. An important facet of patient assessment that is often overlooked is the presence or absence of breast ptosis. Breast ptosis is of two types, namely glandular and NAC ptosis, both of which refers to descent of the gland and the NAC respectively below the level of inframammary fold and expressed as centimeters or grade of ptosis. Ptosis can very well be described as the oncoplastic surgeon's friend because it affords you an extra volume of tissue which can be effectively utilized in filling up lumpectomy defects by adapting therapeutic mammoplasty techniques. This is an algorithm proposed by Peter Barry in 2023 to aid in the selection of appropriate oncoplastic surgical techniques. The algorithm begins by an assessment of breast ptosis and divides patients into those with minimum ptosis, mild ptosis, and significant ptosis. As one can see, for most patients with the small tumor breast ratio, irrespective of the grade of ptosis, round block oncoplasty suffices. For patients with large tumor breast ratio, chest wall perforator flap oncoplasty and lipofilling are options. For mild ptosis, depending upon the location of the tumor, direct oncoplastic excisions as proposed by Krishna Klo in the form of lateral mammoplasty for upper outer quadrant lesions, a DLR oncoplasty for upper inner quadrant lesions, a V mammoplasty or a J mammoplasty for lower quadrant lesions, and a Grisotti flap for central region lesions is advisable. Finally, when it comes to large volume breast with significant ptosis, oncoplastic reduction mammoplasty or therapeutic mammoplasty becomes the procedure of choice to ensure a cosmetically acceptable outcome. Now let us have a look at few of the level 1 oncoplastic procedures collectively called periareolar mammoplasties, which often form introductory skills to be acquired in oncoplastic training. There are few principles that are common to all these procedures which I will enumerate. First and foremost is a periareolar region of deepithelialization, which can be in the form of a crescent, a bat wing, a hemi-bat wing, or a donut concentric to the nipple areola complex, and hence the particular names. The second feature is that an access incision is often made at the outer aspect of this deepithelialized zone, followed by mastectomy plain flap raising. The third step is full thickness glandular excision, ensuring oncology clearance. The fourth step is glandular reapproximation by advancement or internal rotation mastopexy techniques. And the last step involves redraping the skin around the nipple areola complex by using purse string sutures. A classic level 1 oncoplastic procedure described for upper outer quadrant lesions is the lateral mammoplasty, where a tennis racket shaped incision is strategically designed to include the tumor site in the upper outer quadrant, followed by a full thickness excision from the skin down to the pectoralis fascia and final closure by glandular rotation. A useful modification of this classic technique would be to design the incision in a lacy-S fashion so as to minimize scar contracture and NAC deviation. And yet another modification is what is shown in this case, where there is a rotation advancement to add more
bulk and remove 2 tumors in the upper half of the breast, wherein you are harvesting and recruiting more of the axillary fat and rotating that after deepithelialization beneath the medial flap that is created. For the lower quadrants, we have the J mammoplasty and V mammoplasty, respectively for lower outer and lower inner quadrants. Both these procedures are mirror image procedures where a wedge of tissue containing the tumor is removed, followed by glandular rotation and mobilization to fill the defect. At the time of glandular mobilization, it is very crucial to remember that you should not go closer than 30 degrees to the breast equator, as shown in this video. Central retroareolar region tumors, which were traditionally treated with total mastectomy, have now been successfully conserved by using resortive flap, which is a laterally based thermoglandular rotation advancement flap, as well as techniques like wedge mammoplasty, as shown in this video. Next, we come to the upper inner quadrant, which is widely known as the no man's land in osteography, because of the multiple challenges that it throws up, namely limited volume of breast tissue available with limited mobility and widely considered a social area of the breast where direct incisions are taboo. In personal practice, I have found a novel finish technique called the dual layer oncoplasty particularly suitable for tumors in this area. The technique essentially involves a circumvertical incision as shown with medial access to the mastectomy plane and wide local excision as usual. Subsequent to the wide local excision, the medial half of the breast is then mobilized iteratively as required to rotate upwards and fill the lumpectomy defect. The final problem that remains is the redundant skin that needs to be redraped over the new breast mount. And this can be accomplished by deepithelializing the skin in the circumvertical zone and redraping the skin over that area and tailor tacking followed by final closure. What this technique achieves is that it transfers the incision from the upper inner quadrant to an aesthetically more appropriate and least visible location in the breast, which is 6 o'clock. And over time, this technique yields good projection and excellent aesthetic results. And these are pictures 2 years post-radiation. According to the Ghent consensus of 2003, a perforator is a blood vessel which arises from one of the axial blood vessels of the body and either passes through or in between the deep tissues to reach and supply a defined block of skin and subcutaneous fat, which is termed the perforosome. Depending on the path taken by the perforator, it can be a direct cutaneous perforator, a subcutaneous perforator, or a myocutaneous perforator. This very important diagram from a landmark publication shows a central perforator, its perforosome, and connections via direct and indirect linking vessels to 2 adjacent perforators. The direction of blood flow through this perforator system is very important to know in that it directly decides the orientation of the skin paddles of perforator flaps. Basic anatomic studies by Michael Senser has shown that the direction of blood flow through these linking vessels is away from the midline in the trunk and longitudinally in the limbs. Now, this information helps us to design the skin paddles of perforator flaps in such a way so as to incorporate maximum perforosomes into our flaps and thereby increasing the vascularity. The workhorse perforator flap In the lateral thoracic region is the lateral intercostal artery perforator that arises from the costal segment of the posterior intercostal artery. Similarly, the anterior intercostal artery perforator and the medial intercostal artery perforator arises from the muscular segment of the anterior intercostal artery in the anterior thoracic region around the inframammary fold area. The peculiarity of ICAP, MICAP and LICAP perforator vessels are that they have a shorter pedicle length, and most of the times these flaps are inset in a flip over fashion. Now, in contrast to this, the lateral thoracic artery perforator flap and the thoracodorsal artery perforator flaps have longer pedicle length as shown in the picture, and hence are more versatile in that they can be propelled into the lumpectomy defect as a true propeller flap. An anatomically useful landmark to identify the LICAP perforators was described by Stephen McCulley and termed the triangle of plenty. This topographic triangle lies at the infralateral border of the breast and is formed by the inframammary line, anterior axillary line, and the lateral breast fold. This supermarket of perforators is important for two reasons. Number one is the anatomic constancy with which LICAP perforators are found in this area. And number two, since these perforators are very close to the breast footprint, flaps based on them can be easily inset inside the lumpectomy defect in the breast without causing much loss of flap length. Next, we move on to volume replacement with perforator flaps. And the workhorse perforator flaps in the axilla are the LICAP, LTAP, and ICAP. And foremost to utilizing these flaps is an accurate identification of their anatomy. You can see that the LTAP vessel is more medially located in the axilla, with the ICAP vessel lateral to the thoracodorsal pedicle. Now here, this picture is showing the LTAP vessel coursing along the chest wall, and that is the intercostobrachial nerve. And this vessel, which is running freely in the axilla anterior to the intercostobrachial nerve and lateral to the thoracodorsal pedicle, that is the ICAP vessel. Now this flap we have harvested based on all these vessels. So this will be a composite LICAP, LTAP, and ICAP flap. Now the defect, as you can see, is in the lower outer quadrant of the right breast, and we have used a flip over perforator flap to fill that defect, and the skin gets draped over, and the incision, which is a lacy S incision in this case, as described by Farid Maybody, is closed in layers after inserting the drain. Moving on from the lateral thoracic region, when it comes to volume replacement in the medial half of the breast, upper inner and lower inner, it is the medial intercostal artery perforator flap that forms the workhorse in the anterior thoracic region. As you can see, this patient had a large T2 tumor in the upper inner quadrant, which was removed through a periareolar incision. And you can see the MICAP flap harvested, which is used to fill the defect through a tunnel created in the lower part of the breast. And this is the final postoperative result. A less well-known surgical technique for volume replacement in the lower quadrants is the anterior or reverse LICAP. Now, this flap resembles the conventional LICAP in that the perforators involved are the same in and around the area of the triangle of plenty. However, the skin paddle is designed in the reverse orientation, meaning it is designed from the lateral breast crease medially towards the midline. Now, as shown in this video, subsequent to tumor resection through a lateral inframammary fold incision, the same skin paddle that you harvest for an ICAP or a MICAP flap is mobilized off the chest wall, taking care to preserve the triangle of plenty perforators, and the flap is then inset in a fold over fashion, and the skin is redraped over. The inframammary fold is then reconstituted, and this is the final result. To offer my concluding thoughts and take-home messages on this topic, always try to maintain breast form and shape at the end of any procedure. Do the simplest procedure that gives an acceptable result in your hands. Only perform techniques within your own skill set. Do not compromise wide local excision for better cosmesis. Choose safety over perfect cosmesis whenever possible, and always aim for a single stage surgery. Lastly, I would like to remind everyone listening to this talk that this was just chapter 1 of oncoplastic breast surgery. There is indeed a vast array of oncoplastic techniques, including therapeutic mammoplasty, that has been deliberately left out for want of time. I would strongly urge everyone to initiate and polish your oncoplastic skills, because that is one surgical superpower which not just gives your patient their life back, but also enhances their self-confidence, body image, and overall quality of life. Thank you.
Thank you, Dr. Shafiq. A very good compilation of oncoplasty techniques for everyone. And we'll come to you with the Q&A after talk of Dr. Sandeep Naik. We move on to third video for today, which is on robotic mastectomy, reconstruction, and axillary dissections. And that will be delivered by Dr. Sandeep Naik, who's from Bengaluru and is the director of Department of Surgical Oncology at Fortis Cancer Institute. We'll begin with his video. So,
you're playing directly or? Oh, okay. Rijan, you're playing it or you want me to comment something before?
Video will be demonstrated.
Dr. Sandeep, any comments from you before I begin the video?
Yeah, I thought, see, we had two very beautiful presentations, Dr. Ashutosh and Dr. Shafiq. Excellent, presentations. One thing which I wanted to tell the audience is, see, what they have spoken are the well-established techniques which we all practice. What I want you to, what I want to convey here is that, this robotic or endoscopic techniques which we are now exploring are some things which are very new and cannot be as of now considered as standard of care. So when in selected cases and well-planned manner, we can execute this, but it requires a lot of thought and lot of understanding of the procedure before you can implement this. And before you play the video, I want to thank the IASO for inviting me and giving me this opportunity. If possible, I would like to show few slides after this, because this is my standard which was available with me. I put because I could not prepare a separate video for this. I've just sent my video which was ready with me. So you play it and then maybe some slides if I can, then we'll see. Okay. Thank you.
In this video, we'll be demonstrating robotic axillary lymph node dissection, which is being performed as a part of robotic NSM for a confirmed breast cancer. This is a young patient with breast cancer on the left side who has undergone total neoadjuvant therapy with excellent response to chemotherapy. It was a multicentric disease, so we had planned for NSM for this patient along with an LD flap reconstruction because the breast size was small. We have started with the 4 centimeter axillary incision as shown here, and we created the space for placing our port. So while we create the space, we complete the visible part of the surgery, that is whatever we can complete from the axillary incision through direct vision. So you can see we are using a lit NSM retractor. Once that is done, we place the SILS port and we start the robotic axillary lymph node dissection. So you can see the pectoralis major muscle here, and we score the clavipectoral fascia and enter in between the major and minor muscle to dissect the interpectoral group of lymph nodes. So the lymph nodes are pushed towards the specimen. In this patient, there is not much lymph nodal tissue there. Once that is done, we score the clavipectoral fascia at the level of pectoralis minor. So that is the pectoralis minor muscle. And enter the axilla. We run along the lateral border of pectoralis minor. And enter the proper
Dr.
axilla.
Srijan, I think it is
Next step
stalling
is
and
to
it's
identify
coming
the
slow.
axillary vein, and that is the axillary vein over there. So we remain inferior to the vein so that we don't do over dissection of the lymph nodes. There are two axillary veins here, which is seen in about 40% of the patients. We remain below the axillary vein. And run along the axillary vein so that we complete the axillary lymph node dissection. This patient had clinically palpable lymph nodes prior to chemotherapy, which were confirmed to be positive on ultrasound guided true cut biopsy. Following chemo, she has had a good response. So you can see some of the tributaries to the axillary vein, and as we go laterally, we can identify the other tributaries like the lateral scapular branch. So that is the continuation of the axillary vein. And that is a level 2 dissection. So you can see the pectoralis minor in the roof. As there are no significant lymph nodes currently, we don't need to do level 3, but in case it has to be done, it is possible to do in this robotic technique. So now we are defining the medial border of our dissection. We need to identify the nerve to serratus anterior muscle. That is the intercostobrachial nerve which is cut. And as you see there, that is the nerve to serratus anterior. So that is preserved carefully. Laterally, we need to identify the lat dorsi pedicle, and you can see the nerve to lat dorsi. The glimpse of the nerve is visible right now, that is a nerve, and we dissect inferior to the nerve so that the vessels are preserved. As we need to perform the LD flap for the purpose of reconstruction, we'll be cutting the nerve later on. That is a further dissection and isolation of the nerve to serratus anterior. I'm not grabbing the nerve, I'm just retracting the nerve so that it is not damaged. We can preserve the nerve neatly. That is the lat dorsi nerve. We define the lateral boundary of axillary lymph node dissection, which is the lateral boundary of or lateral border of lat dorsi muscle. You can see the lat dorsi pedicle over there, which is carefully preserved, again for a reason that we need the muscle for reconstruction in this case. So the lat dorsi pedicle makes the lateral boundary of dissection for us. So that is the dissected specimen, which is extracted through the primary port. You're welcome to watch the next video on the robotic NSM and LD flap reconstruction. Before we complete, you can see the anatomy of axilla, you can see the axillary vein, the lat dorsi pedicle, the nerve to serratus anterior, and the subscapularis muscle. So that completes the axillary node dissection. Thank you. In this video, I'll be demonstrating robotic NSM the mastectomy part and the reconstruction using lat dorsi flap. For understanding the raising of flap and docking, you need to see the first part of the video, which is the robotic axillary lymph node dissection. That is the pectoralis major muscle. We raise the breast tissue from the pectoralis using monopolar cautery. It is similar to what we do when we perform open surgery. So you can see the breast tissue being raised from the pectoralis major muscle and the perforators being coagulated. As we go medially, we have to make sure that we are complete in our dissection of the breast, and at the same time we should not perforate the skin flap. There should not be a buttonhole. So that is made sure by the bedside assistant, who will be constantly looking at the skin and palpating it as and when required by the operating surgeon. This particular patient has had a breast biopsy previously, so you can see some amount of scarring in this area, and that was a kind of an hindrance for us in this particular surgery, as we had to doubly make sure that our planes are right. This is the inferior boundary of mastectomy. Here we have defined the lower border of resection. The border which was defined in the open part of the surgery is continued. So that is the scar tissue of the previous surgery. You can see the assistant palpating to make sure that we are not thick or thin. You can see the perforating vessels coming from internal mammary over there. So that indicates that our medial boundary of dissection is complete. So once that is done, whatever left behind as anchoring is cut. And the breast tissue is completely free. So the assistant palpates the thickness of the flap to make sure that we have removed the breast tissue adequately. So that is the specimen extraction. You can see it comes out through the port very easily. And next step is to perform robotic lat dorsi flap. Patient is placed in lateral position. Port is the same, we don't change anything. And we dock the robo. Once that is done, we raise the flap. We try to take as much fat tissue with the lat dorsi muscle as possible so that we have adequate volume, because this patient has refused to have a prosthesis. You can see the latissimus dorsi muscle. That is the latissimus dorsi muscle, and that is the anterior border of the muscle. We go along the anterior border of the muscle to reach the iliac crest where the muscle gets attached. And we disconnect the muscle from the bony attachment. Here also we take as much fat as possible because muscle will eventually get degenerated. This is the region of the scapular attachment of the lat dorsi muscle, and we'll have to dissect the or transect this attachment. So we're defining the upper border of the muscle. The muscle tissue is freed from the deeper planes. Here there will be decussation of muscles with the serratus anterior as well as serratus posterior many times. The muscle is transected or freed from its attachment to the iliac crest. While cutting muscle, the camera gets foggy. That is something which we have to deal with in many superficial surgeries. So that is the lower end of latissimus dorsi muscle which is cut and reflected upwards, and we proceed towards the posterior attachment to the lumbosacral fascia, which is also cut and the muscle is freed. As we go up, we reach the attachment of the muscle with the scapula, which has to be freed. So that is the scapula, the tip of the scapula. So that is the completely mobilized lat dorsi muscle along with its fat. Last part being freed. We confirm that the nipple areola complex is well vascularized because that is the area which goes into necrosis. Once the vascularity is confirmed using indocyanine green, we fashion the flap and fix it into the space, looking at the cosmetic outcome. So this is the post-operative picture. You can see the incision, the back of the patient, and the frontal view to understand the cosmetic result. Thank you very much. This is the team which was involved in the surgery. Thank you again.
So I think we've come at the end of the 3 videos, and considering we have another 10 minutes of remaining, Dr. Sandeep, would it be okay if we go through the Q&A
Yeah, that's
first?
perfectly fine. See,
Yeah.
only thing which I wanted to convey was that, see, that's not the standard of care, and the evidence which is available is very less for this. And you see, it's not just robotic, it's minimally invasive breast surgeries also. MIBS also is an entity where endoscopic surgeries are performed. So that much message I wanted to draw.
So,
Yeah.
so why don't we do one thing, sir? We'll start with you with the Q&A. It will be a continuation of the video itself. I think these questions, 4 questions, are common for all the surgeries throughout our this module of webinar. So the first would be to you would be any specific instrumentation required. Now we know this was a robotic surgery. We could see 3 arms were used, 1 camera and 2 robotic arms. You had the scissors on the right and the probably a bipolar or a grasper on the left. Other than that, you mentioned 2 specific instruments in this. One was a retractor, the NSM retractor, and the other was the SILS port. Could you tell us in detail about those 2? Are there any specifications regarding those that you've utilized?
So, see, as far as NSM retractor is concerned, this is basically a right angle retractor with a long blade. So there are various names. Pereira retractor is available. There are many which are available for NSM, particularly designed for performing NSM. Because there's basically for long flaps. To raise long flaps, you need light, you need suction, because your cautery will produce a lot of fumes when you're doing that. So that is one. And this retractor is used across wherever we have to create a very long tunnel under the skin. Now, apart from that, you asked me about the retractors, SILS port. Here, if you look at the say Taiwanese and Korean surgeons and all of them, many of them are using the Alexis port, the one which simple Alexis which comes with the cap, single, for retraction, sorry, specimen retrieval, that port. And they are using glove on top of it and using that as the port. So generally it's called glove port, and that is quite useful for performing endoscopic surgeries. Okay, endoscopic and robotic. Now there are multiple. See, specifically for SILS, there are particular ports which are produced by companies. There is a port which is for 1 centimeter to 4 to 5 centimeter, a smaller one. What you saw me using here was a 3 cent. They say it is for 1 centimeter to 7 centimeter or so, but it is ideal if you are using it for anything bigger than 4 centimeter to 7 centimeter. Like, if you want to do LD flap and mastectomy, NSM, this is a good port. But if your target is to do a breast conservation surgery endoscopically, then you should opt for a smaller port. So these are the specific requirements, but jugaad is possible. You can use glove on top of it and cut the tip, fingers, 1 or 2, whichever number of fingers you want. You can use that, one as camera, other 2 as instrument, 1 more for suction, and 1 more will be still left. So you can do multiple things with the same thing. It is possible to do.
Excellent, sir. The second part of the question is, I think you already said we need more evidence, so we'll leave that part of it. What would you think is the learning curve? Do we have an answer to that question, and if not, what would be your guess?
Okay, so see, evidence-wise, there are some, systematic reviews which are available, but they are very, very small. In fact, many of them which are talking about two published trials and all those things. They're not trials, retrospective. And much of the work is coming from the Eastern world. Okay, so then learning curve-wise, I feel, see, it is if somebody is starting straight away into this, it may take means directly into only breast. A breast surgeon goes into this, it may take about 25 cases to really have some hang of this, is what is my guess. That's why guess, because looking at other things, 25 to 30 cases is what I expect. The surgeon should be willing to revise the flap if need be. Because see, we have done it. We have done even in open surgery, when the flap becomes thick, we do revise it many times. So that bit of a thing the surgeon should be willing to do. That is one criteria. And perforations, if you perforate the flap, you are in trouble. Frankly, I feel endoscopic is better for breast than robotic. If you ask me, it gives one advantage that the surgeon has is it is hands-on. You're standing next to the patient. You can feel the thickness yourself. You are at ease when you're raising the flap. And we are doing we are just, maybe about 10 cases of endoscopic breasts we have done so far. So we are comfortable, especially breast conservation, we are much more comfortable with endoscopic than robotic. NSM, of course, robotic has some advantages, but you should be careful. That's all.
Right. The next one is you said about flap and perforations, but were there any mistakes by your team in the beginning first few cases which you feel anyone starting this case would also face?
No, not, but that's all. See, the on-table team is extremely important, because they should always look at what's happening around. So unless that is the only thing which matters here, because it's a constant communication between the surgeon and the on-table team. Otherwise, it does not work.
Perfect. And post-operative management, how does it differ from a routine NSM and LD flap?
It's the same, as such, you don't have much difference, but only, see, wound related things, and see, it's too early to really tell you that, there is a huge difference or anything like that. But as such, we did keep the same period of time. Patient was in the hospital for about 5 days or 6 days after surgery, which we do the same for open surgery also. So, I think it's too early to really comment on these outcomes and all that. We are too, I can't say we have done hundreds.
No,
When
fair
I'll
enough.
tell you.
No,
Yeah.
the fair
Yeah.
responses from you, sir. Thank you so much.
Yeah.
I think now I'll invite Dr. Ashutosh Mishra, who spoke on sentinel lymph node biopsy. And you spoke on ICG, and I think there was a question from Dr. Anil Herur, a senior surgeon from Mumbai, and he was also asking, if you don't have a handheld ICG machine, would a laparoscopic camera, which is ICG enabled, fluorescence enabled, would that be okay for SLNB for the axilla? Other than that, if there is any other specific instrumentation or advice from you, we would like to hear about that as well.
So basically, yes, we can use laparoscopic camera, but there is difficulty for assessing the real-time trickling of fluorescent in the lymphatic. But once you have opened the axilla below the clavipectoral fascia, then definitely you can take some advantage of laparoscopic camera in assessing the lymph nodes. Because with the help of that camera, we are doing lymph node SLNBs in ovaries, endometrium, and this vulval cancers. So yes, it's doable. Another cost-effective methods currently available in India in various centers are the fluorescein and ultraviolet torch light. So they are injecting fluorescein dye as a fluorophobe, and they are tracing the lymphatic with the help of ultraviolet torch. It's very cost-effective and it's doable. So these are the things that you can start with, and methylene blue is a excellent choice. 1% methylene blue you can inject, and over the period of experience, you can increase your identification rate beyond 95% or 97%. But that takes time, and at least 15 to 20 cases you need to be expert in single dye methylene blue for upfront cases.
Perfect. So you answered the learning curve part as well. If I have learned SLNB at my center and now I go and join a new center and I am an expert, do I need to again validate my SLNB protocol in the new institute?
No, currently in entire world, most of the SLNB protocols are validated. So there are fixed protocols, the quantity of the dye, the site of the dye, the number of your places, number of places you are injecting the dye. So it's all validated. So it's a already validated process. You need not to validate it again.
Perfect. And you train so many residents at AIMS, what are the common mistakes that trainees make while training for this procedure?
So basically, for the assessment of sentinel lymph node, you have to be very clear actually where you want to pick that sentinel lymph node. So one advice I would like to give all the residents or training while you are trying to identify the sentinel lymph nodes. So whenever make an incision below the axillary hairline, and when you are digging below the clavipectoral fascia, keep your this cautery direction towards the chest wall. So don't go away from the chest wall, because most of the time they are in the zone A. These are the lymph nodes are medial to LTV, long thoracic vein. So if you are hitting some vein or something, then you are close to that particular area most of the time. So that one. Otherwise, you can see some blue lymphatics. You can chase them, or if you are using ICG, then that might be helpful.
Perfect. And do you put any drains while doing SLNBs, and post-operatively, what are the specific instructions as pertaining to shoulder movement and physiotherapy?
So it's very minimal invasive procedure. So we are not putting any drain, and we make sure there is no active bleeding or something. You need to take care of hemostasis, and simple. You can put the vicryl sutures, then monocryl in the skin. So no special precautions, and lymphedema rates are almost less than 3% for sentinel lymph nodes if sometime it happens, and there are minimal exercises and restriction for the axilla as well.
Perfect. Any tips from Dr. Shafiq or Dr. Sandeep for the SLNB part of the video? Any comments?
No, I work in a center where we actually do the single dye technique for a past 5 years or so. We have developed our own technique called the lymphatic flare technique. It's very simple to do and easy to learn, published in IASO. We use a very small, minute amount of dye, use an insulin syringe, whether it be ICG or isosulfan blue or methylene blue. And a total of 0.1 ml is injected. So the basic funda is that you use insulin syringe, and when you inject very superficially with the bevel of the needle pointing up, if you get a flare, as in the dye suddenly entering into the intradermal lymphatics, which are valveless, it initiates a contraction, a series of wave of contractions of the lymphangiomes, which takes the dye directly to the axillary nodes. It's almost instantaneous. So no need for breast massage. So it's very easy to pick up and do. So we adopt this technique for all scenarios, and I found it very useful. So ever since we got ICG, as Ashutosh has beautifully mentioned and presented, it's really magic, and we stick to ICG for most of our cases.
Dr. Sandeep.
Yeah, see, we are using ICG for a long time now, and we follow the same technique, double dye. We are always using double dye though, methylene blue plus ICG. But, one thing which, is important to, which, about standardization also and validation of the technique. Validation, as Dr. Ashutosh has said has been done, but, you should look at sometimes I've seen initially when many surgeons try doing sentinel node biopsies, I've seen some samples having 6 lymph nodes and all that. So 8 lymph node that almost turns out to be almost a complete axillary lymph node dissection. So focus on the technique, see what you're supposed to do, track it, identify the node, and then take it, and that is very important. And maybe it's a site where they're putting the incision, and or what it is, I don't know, but you have to, it should never be more than 4, right?
Yeah.
Yeah.
Yeah, so here I would like to add, so as a standard, at least 3 lymph nodes you need
Yeah.
to harvest to minimize the false negative rate. And if you are doing in post NSCT setting, always do with the dual dye technique. If in upfront setting you are expert enough, then single dye is enough. Otherwise, the combination of dyes is a choice. And one more thing, if you are doing ICG, then always clip your lymphatics. Don't spill the ICG dye here or there or in the gloves or somewhere else. Otherwise, that will contaminate your field, and it's get difficult to find out the sentinel lymph nodes later on.
Dr. Ashutosh, do you recommend for post NSCT cases also? Because two
Yes,
things
we are doing, sir.
Okay, for N0 or N plus also?
We are doing in N plus also.
So
We
you're
are doing
clipping and
last
doing
2
it?
years. In some of the cases, we are clipping it, lymph nodes as a part of our thesis
Okay.
protocol, but we are doing for last 2 years, and very soon we'll generate the data.
Okay. I think, it's interesting because, the available data is for dual dye, and, again, you have to validate, make sure, people who are doing it. In fact, we are validating to see whether our, we are able to get, what is our accuracy rate and all that.
Even in recent thesis, we have given post NSCT single dye because we are able to chase more than 95% in dual dye. So now
Yeah.
we are focusing on single dye in post NSCT setting.
But single dye 80% is the, this one, no, sentinel node detection rate.
For
80%
this is 80% is for the 80 to 90%. It's 80 to
Okay.
86, 87% upfront cases methylene blue by ICG or all these things. And even methylene blue, if you are doing it regularly, you can reach up to
No, I'm talking
97.
post NSCT.
Post NSCT, yes, sir. It's
Yeah.
quite low
It's
in
only
methylene
80.
blue.
Yeah.
Yeah.
80% only.
I have a question for Ashutosh, if you don't mind.
Yeah.
Ashutosh, this is regarding the post NSCT setting. We all talk about using the dual dye. And as you mentioned, in our center, we do use the ICG with the blue dye. But often we find that it is the ICG which actually matters in the end. And the blue dye adds, very little in terms of identifying the sentinel node. So what has been your experience on that? Have you had really blue nodes, or how often have you had blue nodes post NSCT setting, which were the true sentinel nodes?
Yeah, so I absolutely agree with you. So most of the time, this is the ICG actually we picked up, and it's blue dye take up by the lymph nodes is lesser than ICG. So as a single dye, we have checked in 95% of the in post NSCT setting, it was almost false negative rate was 12 to 13%. And for methylene blue, it was much more. So we have to be a bit cautious if we are doing single dye, but in combination, definitely it's helpful.
Right. So I think great discussion on SLNB. We'll move on to the last part, which was the oncoplasty. Now, I know we're not talking of any specific instrumentation when it comes to oncoplasty, but for perforator flaps per se, would you recommend using a Doppler? Do you use a Doppler? Do you use loops? Or any other thing that you might want to add, Dr.
Yeah, I would like to answer this question in a different way. I mean, maybe you can rephrase the question as rather than a specific instrumentation, the key things that you need, which are very, very simple, but very crucial. I would say one is to have the oncoplastic mindset. Most people talk about oncoplasty as a set of skills, but people, when you really start doing the procedure, you'll understand it's a mindset, because there are so many procedures to choose from. You have to have that aesthetic eye to have an idea about how the breast is going to turn up. So that only comes from experience and guidance from mentors. Number two, the two other things which I daily use in every single case is a permanent marker, because marking and planning the surgery, especially in advanced oncoplasty like perforator flaps or therapeutic mammoplasty, is 50% of the procedure. And you want to be very accurate with your marking. The second thing is a measuring tape, a simple measuring tape. Now, when you start off, the measurements like from the sternal notch to the nipple distance and all matter a lot when you learn your mammoplasty markings. But as you go along and you gain more experience, you do more of freehand marking, and the measurements just serve to confirm symmetry between both sides. So a good marker, a good measurement, and an oncoplastic mindset are absolutely required. Now, your question on Doppler, early on when you're planning perforator flaps, it's always advisable to mark your perforators and learn good use of the handheld Doppler. And the one other advantage of marking out the perforators is that you know exactly where the vessels lie, how many perforators are there. One thing which we often overlook when we talk about the anatomy of perforators is that we assume that they are always there, which is not the case. Even vessels like the lateral thoracic artery perforator or the axillary artery cutaneous artery perforator, these vessels may all be absent. Sometimes you get just veins without arteries. So you have to be prepared for all these, scenarios. And that is where the Doppler marking actually adds, inspires a lot of confidence. And to add to this, I would advise all of you to go and read up on Ashutosh's paper on his special technique that he described, the no Doppler single position technique of perforators. That's something which also can be done with experience.
Perfect. I know oncoplasty is not one procedure. There are so many procedures. But if we were to ask you, starting from level 1 oncoplasty to level 2, do you think the learning curve differs significantly when you go to more complex oncoplasties? And what do you think should be the number of cases you need to do before getting your complication rates down?
If you look at oncoplasty as a whole, what I mentioned during my video was, it was just chapter 1 that I mentioned. It was mostly level 1 procedures, taking into consideration the audience who is likely to be here. The advanced oncoplasty procedures are a different ball game altogether, because we must ultimately remember that all these are not done for cosmetic reasons. Primarily, these are for cancer patients. So patient safety comes first, and any detriment to patient safety is likely to result in a detriment in the survival of these patients, because it's going to delay adjuvant therapy. So you don't want to land up in complications trying up complex mammoplasty procedures. Most of the time you can ensure good aesthetic results by simple mammoplasty or simple oncoplasty procedures. So initially I would advise, and this was my learning curve, advise everyone who is interested in oncoplasty to start by being familiar with your anatomy. As you do your mastectomy, look for all the perforators. Don't dismiss any perforator. Pause, have a look at where the perforator is, see which all perforators are pulsatile, and give a lot of time and attention to preserving vessels in your axillary dissection if you can find the time. Because ultimately, all about perforator flap, which is level 2 advanced oncoplasty, has to do with how well you can dissect out your perforators in the axilla. So spend time on those basic skills. And then the ideal step, which we often see our residents also, as they learn here in our institute, is you start off with the periareolar mammoplasties, which I mentioned, the round block, the crescent, the batwing procedures. And as you do and then the the V mammoplasty and the J mammoplasty, these are all easy to learn and safe procedures to do, which will give you a lot of confidence. And I will say the learning curve for all of them is around 5 to 10 procedures max. But when you go to level 2, therapeutic mammoplasty and perforators, I think that has a much higher learning curve of up to more than maybe 25 to 50 cases.
Right. The question about common mistakes, if you choose the periareolar round block technique that you must be teaching your residents first, What are the common mistakes residents make while doing that technique?
Okay, one of the mistakes that I think I notice is, apart from selecting the right patient, I mean, you don't want it, the lesion has to be right, the patient has to be right. So you don't want a lesion which is beyond the areola by more than 4 centimeters to do a round block. It is technically possible to dissect all the way from the areola to the upper pole of the breast and then take out a lesion there, but the resultant scarring that results, that actually leads to a lot of retraction and displacement of the nipple areola complex despite your best efforts in the long term. So most of these results might look very good on table or immediate post-op, or maybe 1 month, but RT is what decides what happens in long term. So unless you see your patients beyond 2 years, you never really know. So confine round block for lesions which are not beyond 4 centimeters. And then the other thing is, which I have noticed, is sometimes after resecting the lesion, till that point everything looks fine. Something peculiar happens to the skin, which we know from experience. When you go in the mastectomy plane and the Cooper's ligaments are cut, the skin in most of the young patients actually expands a little bit, and you find that you have a sort of redundant skin. And then when you close the glandular tissue and try to just bring the skin over it, what happens is there's often a denting that you see. So you have to design your periareolar deepithelialization zone with adequate width to take into account this extra skin that may result in the end. So these are 2 points which I would advise all of you to take care of.
Yeah. Any final comments from Dr. Sandeep or Dr. Ashutosh?
Yeah, so from my side, whosoever is listening this presentation, everyone should go for no Doppler single position LICAP technique. So by reading that article, just find out those anatomical landmark, and anyone, just MS pass out student, can perform all the perforator flaps. Very soon I'm going to publish for the MICAP and ICAP as well. And then you can focus, Dr. Shafiq has told, you need to find out the perforators, but even without the use of Doppler, you can easily do and can raise like a flap up till 30 centimeter or till spine. That much just by following the anatomical landmarks. And oncoplasty, the outcomes of oncoplasty increases as you do more cases by the experiences. Thank you.
Dr. Sandeep.
Yeah, so only the one thought which came to my mind is, nowadays, or for a long time, plastic surgeons can do fat injection or fat transplant. So if there is a defect or a dip in the skin later on, a dimpling is there, it is possible for them to just do a fat transplant and give that cosmesis. So
Yes.
very often, I think when we talk to our patients, any breast conservation surgery, we should talk about necessity for multiple procedures, which may be minor procedures, but to get a good cosmesis, they might have to go for a procedure afterwards also. That thought and that discussion should happen with your patient always. So because after radiation also, cosmetic changes do occur. What you see immediately after surgery is not what is the actual result. So especially sensitive patients, we should they should go for it.
Very pertinent point. So thank you all speakers. I think I've been doing this on my own since the last 4 years, and this is the longest I've stayed for a webinar, and only because all the presenters and faculty today were so relaxed, and no one was in a hurry really, which is great because we could bring out so many important points like the last one Dr. Sandeep just mentioned. I invite IASO Secretary Dr. Rudra Acharya to kindly give his address.
Yeah, I think it was a very beautiful presentation from everybody, especially the radiology part was also quite interesting. She gave a lot of insights, and definitely our surgical oncology colleagues did the best job. Simply, just one line, till now, whatever surgical oncology we are doing, It is pure anatomy based. So anatomy has taught us how to do these oncosurgeries. And the same thing applies to breast oncoplasty. Previously, it was not very popularized. So the type of anatomy now we are reading for breast oncoplasty, we were not reading when we were being trained, especially. Maybe newer students are getting more insights into these type of anatomy. So if you know the anatomy, Doppler is just additional help, but you can know the anatomy, and once you are inside, you can see the vessels, and according to that, because previously we were going to that area, but we were not concentrating on the vessels, how they are the perforators are there, and how they are going to help us. So I think a deep knowledge of anatomy can make oncoplasty much better, and breast science especially has evolved a lot in the last 5 years, both on the basis of axilla, breast conservative surgery types, and oncoplasty. So I think it was a very summation of the whole surgical techniques and a nice presentation by all the faculty. I thank even the Indo-American Institute, especially the team working for IASO Mastery of Surgery. This new concept is working very well, and we are very much thankful from IASO for all of you faculty, Dr. Sandeep, Dr. Astos, and others. Thank you very much.
Thanks for having me.
Thank you.
Thank you, everyone. Good evening.
night.
We'll close the webinar for tonight. See you the next webinar in a fortnight's time. Thank you.
Thank you, everyone.
Thank you.